we'd actually just stopped on this slide. Okay, so just kind of a recap how the immune system and lymphatic systems work together. So the lymphoid organs and tissue provide a place, okay, a residence for B and T lymphocytes where they can be found once they're mature. So they will live in our secondary lymphatic organs, places like the lymph nodes, which remember are scattered all over the body, MALT, which is in our mucosal lined tissues, and the spleen. So lymphoid organs are a place where pathogens can get trapped and where lymphocytes can carry out their effects, which we really haven't got into that much. Also, though, where they can come into contact with other white blood cells as well, like macrophages. So lymphoid organs can help activate the B and T cells of the immune system. So we're talking about the adaptive immune system. A way they play this is by housing dendritic cells, which we're going to go through the steps more tomorrow, which play a major role in activating these specific types of lymphocytes. So the lymphatic system has a closer relationship with the adaptive immunity than innate. Remember, adaptive is specific. It does involve lymphocytes, which makes sense. It's stronger linked to the lymphatic system. Okay, so a little bit of review. Which of the following is not a defense barrier involved with innate defenses? So we have the actual mucus itself, which is thick and traps any fluids secreted from any part of the body. They have proteins in them, so that's a barrier as well. Keratin, which is very strong in the skin, and sebum in the production from oil glands. All of those are protective barriers. Remember, protective barriers incorporate the first line of defense for our body. Which of the following is non-phagocytic, meaning that it does not engulf? Eosinophils are phagocytic against parasites. Neutrophils can be for several things, strongest against bacteria. Macrophages, of course, that's their main function, is a phagocyte. So lymphocytes are the only type that do not engulf. Okay, what type of immunity exists in the absence of a stimulus? Cell-mediated, which involves T cells. T cells have to be stimulated, so that cannot be true. Specific immunity involves cell-mediated, so that's not true. Innate is non-specific. You do not have to have a stimulus. Adaptive, of course, is part of specific again. What are the primary cells of adaptive immunity? So adaptive, again, is specific. Of course, that's going to be your B and T lymphocytes. So the rest of these choices are all examples of non-specific or innate defenses or cells. Okay, so now we're going to talk more about innate internal defenses. So this is once the pathogen has been able to get into the body, what are some defenses that we have that are non-specific or innate? So remember that innate occurs much faster than adaptive does. So we have cells and we have molecules. First, we're going to talk about cells, which we can differentiate into phagocytic, those cells that can engulf, and the cells that cannot, non-phagocytic. So talking about phagocytes, it's going to include macrophages, neutrophils, and eosinophils. Reminder that macrophages are actually called monocytes in the blood. So some of this I know we've talked about briefly before. Now again, we're more going to focus on these cells and how they play a role in immunity more specifically. So macrophages can be activated by several different things: debris, pathogens, chemicals, even that are released by our own damaged cells, and even chemical signals that are released by lymphocytes, part of the adaptive immunity. So we always have some macrophages around, especially in the connective tissue. So that's what we would refer to in a local macrophage, the small type of wound where they can ingest cells and other cellular debris in a small area. They will be the first to respond. They can kill pathogens by exposing them to hydrogen peroxide and hydrochloric acid. Both will basically break down the pathogen. They also have cytotoxic effects. Basically, they can kill. They can secrete substances onto pathogens that are too large, which basically marks them for destruction. Macrophages can also act as antigen presenting cells. A lot of times, for short, I'll call these APCs. These are important for activating B and T lymphocytes. They do this by taking a small part of the pathogen which they've ingested and displayed it, basically showing the lymphocyte the foreign pathogen. T cells respond most strongly, and they have to have the antigen presenting cells, which stimulates them. And so when T cells come to the area, they will also increase the number of macrophages in the area. So this is an example of a positive feedback loop. Macrophages will make more T cells become activated, T cells make more macrophages become activated. And it's positive until the pathogens have been removed. Neutrophils, of course, are another type of phagocyte. They're the one that we have the most frequent, about 50 to 70%. They also use hydrogen peroxide. They use hypochlorous acid and lysozyme. And lysozyme, which are, of course, in the lysosomes, which, remember, most of the time, that's what they fuse whatever they're ingesting and bringing in to help break it down. Of course, remember, name significance is that it doesn't pick up a distinguishable stain by its granules. So these can ingest many types of cells, but they are most effective against bacterial pathogens. So in bacterial infections, you'll see a higher incidence of neutrophils than other types of infections. So they, like the macrophages, release cytotoxic contents onto the pathogen, which damage the plasma membranes. Cells that have damaged plasma membranes a lot of times cannot survive. Unlike macrophages, these do not stay in tissues. They're in the blood. So these chemical signals, chemotaxis that occurs, basically tells them where to go and recruits them. Eosinophils are also phagocytes that, like neutrophils, are in the blood and can migrate to tissues where they're needed. Again, remember, the name is because of the eosin, the red-orange stain the granules pick up. Eosinophils are going to be increased whenever you have parasitic pathogen, and they can basically cover the parasites, which are much larger with them, with the chemicals that are inside the granules, and they damage the parasite membranes that either kill it, destroy it, or make it easier for other immune cells that are coming because of that chemotaxis that takes place to further destroy. This is an actual scanning electron micrograph that shows a macrophage, and it's starting to engulf and break down some of these bacterial cells. This is a light micrograph. This would be the actual phagocyte right here. It's chasing the little bacterium. You can see some red blood cells. Really cool video. If you think you'd be interested in that, I recommend it. It's pretty cool. Okay, other cells other than those phagocytes. So these are non-phagocytic cells. So these are going to include NK, our natural killer cells, dendritic cells, and basophils. So natural killer cells are particularly important with cancerous cells and viral cells, specific ones that we're really not going to get into. They are not part of adaptive immunity and are part of innate because they cannot recognize specific antigens. They too can be cytotoxic. So they release substances, as it shows here, into target cells, which typically are viral or cancerous, which can destroy their outer membranes. They also can make antimicrobial cytokines that will help activate other immune cells, macrophages, and that will increase the macrophage's ability to phagocytose. Dendritic cells, like macrophages, also work as antigen presenting cells, APCs. So they can ingest and show T cells, also B cells, the piece of antigen which helps activate it. So they're a very important role in the activation of cells within the adaptive immune response, although they themselves are part of innate or nonspecific. Basophil, remember, are the least frequent types of white blood cells, typically around 1% or so. They contain granules that have histamine, which of course is a inflammatory chemical. So typically they're in blood. They can go in tissues where they become mast cells. A lot of times they're going to be very close to mucous membranes, which of course are exposed to allergens, which is a place where we would release these mast cells. So whenever they release the histamine, they're going to trigger the inflammatory response that we're going to talk about. And we specifically will have a lot of mast cells released in allergic responses. So typically you'll find these where you have eosinophils that are also important in allergic response. Another important part of the innate immune system are antimicrobial proteins. And a specific type of these antimicrobial proteins are complement. Complement is a group of about 20 or so plasma proteins that are made, once again, like most plasma proteins, by the liver. Complement proteins are named with basically a letter and a number. Sometimes they'll even have like a subletter. I'm not going to make you memorize that order, although I will want you to know a little bit about the common pathway. So they circulate in inactive forms. They must be activated by a complex cascade of events that's turned on by enzymes. Sounds very familiar. We just talked about basically the same thing with blood clotting, coagulation, or hemostasis. We have two different pathways essentially that can activate complement. So we have the classical pathway, which is activated when antibodies bind to an antigen and make immune complexes. Okay, that will make the inactive complement portion become active. Or the other pathway is the alternate, where the inactive complement actually encounters an entire foreign cell. Most typically, we see this with bacterial cells. So I do not expect you to know the details, just know that classical is activated by antibody antigen complex, and alternate is typically by a cell. Regardless, both will basically start with the common portion. They'll end up having the same result. They'll have the activated C3b complement protein. Now you can see all the different effects that can take place because complement was initiated. Okay, so this starts several different effects that we're going to talk about in the body. Okay, so 5 different responses that can be turned on once, again, the common part of complement is turned on, and that again is by the activation of the C3b complement protein. Okay, so we can have cell lysis. So complement proteins will bind to the outside of a pathogenic cell, basically breaking holes in it. We call this a membrane attack complex. And there's little porphyrins that basically have these little holes. So it can't contain its contents. It basically starts leaking, which kills the cell. Okay, complement is also going to increase the inflammatory process that is already occurring as soon as you have injury or exposure to a pathogen. So inflammatory chemicals that are released by basophils You're going to have complement proteins that bind to the basophils and increase the amount of inflammatory chemicals that are released, therefore increasing inflammation. Complement can also neutralize viruses. So C3b can basically bind to all of the active antigen binding sites on the virus, so they cannot carry out their effects onto our cells. Complement is also going to increase phagocytosis due to what we call opsonization. Opsonization basically is kind of coating this, in this case, this bacterial cell with that protein, which marks it very strong for destruction by the macrophage. And also by blocking all the sites, it renders it useless against other cells. And then finally, complement can also get rid of immune complexes. Here we're looking at basically these are several antibodies. This is a specific type of antibody that you have here that's bound to that complement protein, and you want to remove the antibodies that are no longer needed in circulation. Okay, so another antimicrobial protein, we have complement, we have cytokines. These are proteins that are made by specific immune cells, and they increase the immune response in some way. Depending on the cytokine, depends on what it increases or enhances. And again, first we're discussing innate immunity. So one cytokine is called tumor necrosis factor, or TNF for short. This is made by activated macrophages in response to bacteria or possibly other pathogens that they can be engulfing. Basically, this is almost a complete positive feedback loop. So it's released by macrophages. It can attract phagocytes, including other macrophages and other phagocytic cells. It increases the phagocytic or engulfing breaking down capability and releases more chemicals that will continue enhancing this process. And very high levels, you can actually see this lead to septic shock. Where septic shock exists when you have basically the body's responding too strongly to pathogens that are in the body. So like many types of shock, you're going to see a drop in blood pressure, typically see organ failure, especially where you are releasing all of these cytokines. You might have clotting where you don't need it, so you're blocking blood flow further down. And of course, the blood sugar drops dangerously low. Another type of cytokine is called an interferon. A lot of times for short, you'll see these as INFs. Okay, these are also made by macrophages, also made by dendritic cells. Remember again, macrophages and dendritic cells both act as antigen-presenting cells as well, and by the natural killer cells, and certain cells of adaptive immunity, although right now, again, we're focusing more on innate. So basically how this works is one of your own body cells will have a virus. Viruses are all, they have to use our cells because they don't have their own DNA and RNA to replicate. So that's inside the cell. Or there are other types of bacteria that work inside of the cell. And as this cell basically is being attacked, it starts to release these interferons. These interferons go to nearby cells and they basically make it resistant for that virus or other intracellular bacteria to be able to attack that. Viruses, this is very effective. Again, viruses cannot replicate without using our cells, so it stops the virus from spreading. Interleukins, there are several different types of interleukins. There are 29 that we know about. These are produced by lots of different types of white blood cells. They stimulate neutrophils being made in the bone marrow. They're going to stimulate the natural killer cells, and they trigger more interferon to be released. They also play a role in activating the adaptive immune response by activating T cells. We're going to talk specifically about antigen presentation, which involves the activation of T cells. And here you see where two different interleukins are important to allow the T cells to do their job. So because cytokines in some way stop or hinder pathogenic activity, they can be used in therapy for viruses that are very persistent, like hepatitis B and C and other types of cancers as well. Several, like tissue necrosis factor, also induce a flu-like symptom, which of course a lot of times when your immune system's working properly, you'll feel sick because of that. And yes, the actual flu-like symptoms aren't the best, but it does let you know that your immune system is working and it's trying to fight the infection. So those will commonly include fever, chills, and aches and pains. And of course, the aches are due to inflammation and the increased amount of fluid, which we'll talk in more detail. Okay, so now we're going to discuss the inflammatory response that you have been over briefly with tissue repair. We, of course, are going to get much more detailed about it. First, we're going to talk about the inflammatory response acute. So again, this is going to be 2 weeks or less. So this is when a cell is damaged by anything. So this could be a small cut, a bruise, any type of trauma, bacterial or viral infection or invasion, toxins that are released, some type of intense heat that causes damage, or chemicals that have caused damage. An inflammatory response, there are basically two basic stages. You talk about the actual inflammatory chemicals or mediators. That's one stage. And the second stage are the cells, the phagocytes. So if you'd like to watch a video about what we're about to talk about, feel free. So first, the chemicals, the inflammatory mediators, and of course the cardinal signs, the four things that always go with inflammation. So tissue damage, naturally you're going to initiate the inflammatory response because some cells have been damaged. And local mast cells that are nearby also will release these inflammatory chemicals. So these can include anything like histamine, which we've discussed. Others include serotonin, some other cytokines, bradykinin, which plays a more significant role with pain, prostaglandins, and leukotrienes. Several of these cytokines, leukotrienes, prostaglandins, there's several different types. We're just kind of being general for right now. Also remember that complement, those series of proteins, activated complement also is going to release inflammatory chemicals that will initiate this response as well. So the four cardinal signs that you have with inflammation always, you're going to have an increased redness, increased heat, swelling or edema, and pain. And basically this is all because of vasodilation. So the vessels in the area have gotten, if this is normal, they've enlarged because of these inflammatory chemicals that have been released. So more blood is in the area, which is why you have redness, heat, swelling, and because of more blood, more fluid, and therefore pain. Of course, the more blood flow, the better you can help heal, which is the idea here. So we are making more blood come to the area, what we call hyperemia. So of course, this is why you have the redness, heat. Remember, blood is slightly warmer than body temperature. And because you have more fluid, more friction, that will account for some of the warmth as well. So decongestants work to block the inflammatory response. So you will not have vasodilation, you will have vasoconstriction, and we know that vasoconstriction would increase peripheral resistance and therefore increase blood pressure, which is why you would not want to give it to someone who has chronic high blood pressure, hypertension. So vasodilation, you also have increased capillary permeability. So it's easier for certain white blood cells, possibly, to leave the area and enter the damaged tissue to help clean. It also makes it easier for blood to flow. And the stuff in blood, including the proteins, like that have for clotting. Remember, we have the inactive fibrinogen. We have complement proteins that are innate response as well, proteins that will start tissue repair. We need more of these to come in the area. So vasodilation will help with that as well. So some pain can be there because of pressure receptors that are activated because of the increased blood flow. But typically it's actually because of some of the chemicals that are initiating inflammation, like bradykinin and the prostaglandins, will also trigger action potentials down sensory neurons, basically telling you that you're in pain. Pain is a good thing. It tells you that your tissues are being damaged and that you basically need to stop doing what you're doing to prevent further damage. Pain will also, especially if it's severe, stop the function of a particular body part, muscle, whatever it might be. And again, the idea is that you want to stop using it, so you quit hurting it and you allow repair of that part. So pain is basically a way of telling your body that you need to slow down. Inflammatory chemicals also give out this alarm, that chemotaxis, that will attract other leukocytes, specifically macrophages and neutrophils, which are phagocytic, and other complement proteins, which are all part of the innate response. So what you see a lot for immunity are different innate responses will actually have a positive feedback on other innate responses, and that feedback loop will continue until the threat is diminished. Okay, so we had tissue damage occurred first. The damaged cells as well as nearby mast cells will release those inflammatory chemicals. That's going to act on the capillary bed, making it more permeable, making, of course, the arterioles nearby, those respond more to smooth muscle vasoconstriction or dilation. So that's going to dilate, which will, of course, cause redness and heat. You're going to have a more leaky capillary bed because of these chemicals as well, which makes the capillary more permeable, which means that extra fluid and proteins leak out, which is why you have swelling or edema, excess fluid, okay, that accumulates between the cells. These chemicals are also binding to sensory neurons, telling you that you're in pain. And the inflammatory chemicals also give off that alarm, so other white blood cells can use the bloodstream to get to the area and enter the tissue where you possibly have still an infection. So this is all examples of how chemicals, okay, are part of this inflammatory response. Now we're going to talk about the second part, which is the cells, the phagocyte response. So the inflammatory chemicals cause the phagocytes to arrive. And a lot of what happens depends on which phagocyte is in the area. So macrophages that are nearby, and again, you pretty much have macrophages in most connective tissues. These will respond quickly because they are so close. So within minutes, anytime you have the initial injury, they're really important in making sure that any potential pathogens do not spread. Okay, they want to contain them. Do not allow the spread until other white blood cells can come to the area and also help clean. So other cells come because of those inflammatory chemicals, the chemotaxis. You'll have neutrophils, one of the cells. They usually arrive in about an hour and a half. So they basically arrive very quickly compared to some of the other white blood cells. So these neutrophils that are coming to the area because of the inflammatory chemicals and because of the complement proteins in the area. Remember, white blood cells use the bloodstream to get to where they need to go. So what we see, this is your blood vessel. So you have little neutrophils that are basically sticking to the edge. They become sticky. We call that margination. They're going to stick to the edge because they want to leave the vessel and they want to enter tissues where they can actually start phagocytizing pathogens. So the chemicals increase the permeability. It makes the spaces between the endothelial cells of the blood vessels smaller so they can squeeze through. The squeezing through of the leukocyte is what we call diapedesis. So margination is the sticking, diapedesis is the squeezing through. And it enters the tissue and can then carry out its effects. While this is going on, the bone marrow basically is in communication with all these chemicals, so it's going to release stored mature neutrophils that it has into the blood. So the number that you have in the blood is going to increase pretty quickly during this acute initial response. So because of the chemotaxis, you have other phagocytic cells, monocytes, which once they marginate and diapedese and enter the tissue, now they're called macrophages. They can continue to engulf the pathogens and debris. So these are not local. These are ones that have traveled a distance. This is all stimulated leukopoiesis. So more white blood cells are being made by the bone marrow, specifically those that are phagocytic, the neutrophils and the monocytes. So the next 3 to 4 days, you will continue to have these released into the bloodstream as they mature to help ensure that that infection doesn't spread and it stays local. So you could have an increased number of leukocytes to the point where you would be considered to have leukocytosis, high white blood cell count, which just means that you have an acute, a small infection that's going on and your body is responding appropriately. A lot of times if they take the blood cell count specifically, what they're going to see is an increased number of immature neutrophils or band cells released, which is what we call a shift to the left, which basically means the bone marrow is being heavily activated. So the more white blood cells in the area continue to phagocytize, break down, clear away damaged cells so that new cells, fibroblasts, can actually start the healing process. So all of these dead pathogens and leukocytes that die in the process of trying to get rid of these pathogens make this white kind of fluid-like mixture, which we call pus. And pus, of course, we can see, underneath the surface of the skin. You want the body to reabsorb and to get rid of the dead leukocytes and pathogens, either internally or externally. So the first part where the chemicals were activated. Second part, we have macrophages. So macrophages, locally, the ones that were nearby the injury, will start the chemotaxis. Also because of the chemicals that were already released, neutrophils will start to show up about an hour and a half later. They will immigrate based on the chemotaxis. So they marginate, stick to the edge, diapedese, squeeze out. Monocytes are slower to get there, but they'll come to the area as well. Remember, as this is taking place, the chemicals are also stimulating the bone marrow so that more white blood cells will actually be released into the bloodstream to come to the area to fight. So that was acute inflammation as seen with tissue injury. Chronic inflammation is longer lasting, when this is also referred to as self-perpetuating, because basically you have an injury, a sore knee, shoulder, something like that. It's inflamed, it's hurt, and you basically do not stop doing a function. And so you continue to injure and have the tissue around it inflamed. So this can last more than 2 weeks, months, or even years. So first of all, you'll actually see an increased number of lymphocytes, cells that are there for more specific antigens instead of the neutrophils that arrive about an hour and a half after acute inflammation. You no longer have pus, You should actually have the fibroblasts that are laying down the collagen, the scar tissue. So you could see scarring. There could be some adhesions made by the collagen. You might have some extra tissue deformities that can result. One such deformity is a granuloma, which is what this picture is showing, which are basically a lot of macrophages that have been called to the area because you have injury here with a lymphocytes that have also come. You also have these giant epithelial-like cells that have multiple nuclei that kind of get stuck here. And then you have connective tissue. You kind of see the wavy collagen connective tissue that encapsulates it, surrounding it, and that's scar tissue. So the longer an injury has gone on, the more scar tissue typically that you'll have in that area. So other than injury, you doing it basically to yourself that can cause chronic inflammation. So you can have pathogens that are very persistent, or irritants that can't penetrate very deeply or spread very rapidly. You can have certain materials, talc, silica, these very small materials that can get in your skin, asbestos, other suture materials, especially gets in the lungs. It gets embedded and you can form this kind of scar tissue around long term. Some viruses and bacteria, fungi, and larger parasites, parasitic worms, that don't have a high incidence of being damaging. That's what low virulence means. You can have chronic inflammation as well. Knowing the specific scientific names of any of those, don't worry about that. So as we mentioned earlier, pain is one of the 4 signs of inflammation. And of course, people do not like to feel in pain. So a lot of anti-inflammatory medications also help alleviate pain. And they can do this by blocking those chemical prostaglandins from being released. So prostaglandins are related to chemicals called leukotrienes that are made from a fatty acid called arachidonic acid. And this is on almost all the cell membranes that we have in the body. So whenever the cells are damaged or stimulated in some way, there's an enzyme, phospholipase, where ACE is an enzyme that's going to speed up the reaction that basically cleaves or breaks this arachidonic acid. And when that happens, prostaglandins and leukotrienes can be released. So the products of this, 2 main classes, you have cyclooxygenases, which produce the prostaglandins, and lipooxygenases, which make the leukotrienes. So like I said, basically you have the production of prostaglandins and leukotrienes whenever this arachidonic acid is broken down. So non-steroidal anti-inflammatories, okay, NSAIDs, work by inhibiting the cyclooxygenases, therefore not allowing the production of those prostaglandins. This is what we see in ibuprofen. Also, this is in aspirin and naproxen. We do not see this in Tylenol or acetaminophen. So that helps with pain, but it does not actually help with inflammation for that reason. Another type of anti-inflammatory medication that's given are corticosteroids. These, of course, act like the hormone cortisol that we make in our adrenal cortex, which inhibits the formation of prostaglandins and leukotrienes. So therefore, you shouldn't have the inflammation and the pain associated with it. So this is a much wider ranging and it lasts longer. It's a stronger effect. Usually this is used in conditions that have much more inflammation going on, or the inflammation is due from the leukotrienes versus the prostaglandins that cannot be blocked by ibuprofen, aspirin, naproxen. So corticosteroids that can be given, cortisone, prednisone, These can be taken orally, or, sorry, some of this got cut off, or they can be injected at the site. And a lot of times, if you have inflammation at one particular site, a joint or something like that, they will do an injection. And just a note here, this is why corticosteroids long term can be bad, because you are stopping the inflammation. So basically, you're suppressing your immune system, and long term, that can actually make the person much more easily to get sick. So you have to watch out for that. Fever. Fever is defined as the body temperature reaches over the normal range. Normal range is 37 degrees Celsius, but everyone's body varies a little bit. So 36, 38 degrees Celsius, they're really not going to consider that too much with the fever. Okay, so 97 to 99 is normal. It's one of those things that's good to know where you are normally. Do you normally sit more on the low or the high end? So when an individual gets a fever, we refer to that as febrile or febrile, or someone who is feverish, same thing. This is as far as a doctor or nurse, this is a warning that the inflammation process is occurring somewhere in the body. And as long as the fever stays minimal, then it's really nothing to be too concerned about, other than to know that there might be an infection somewhere in the body. And that's possibly what they need to find out. So that's why with particular insect bites, illnesses, things like that, doctors will always ask, is there a fever? Is the fever significant? Fever is a general response, okay? So it's an innate response. It's not specific when you have cellular injury and basically a lot of inflammation going on. So what causes fever to occur are that these damaged cells and certain bacteria can actually make pyrogens be released. Pyrogens act on the part of the brain that regulates body temperature. So they act on the hypothalamus. They basically raise the thermostat. So remember, typically, as soon as the temperature would go up, the hypothalamus would be able to bring it back down. However, when pyrogens are released, they cause the thermostat to reset to a higher range. So it interprets that normal value of 37 degrees Celsius as being too low. So it triggers that negative feedback loop and makes you feel like you're cold or having chills when the fever actually occurs. So a person will feel cold because they're basically telling their body that they want it to warm back up. So you'll see shivering, of course, small muscle contractions, heat's given off. You're trying to heat the body up because you think the body's too cold. So of course, temperature starts to rise. People get worried, so they want to break the temperature. So you can do this by resetting the hypothalamus, allowing it to know what that normal range is. You can do this by making someone sweat, warming them up, which would help dilate the blood vessels. Should you always necessarily do this? No. Okay, a lot of times, again, the fever actually means the body is having a response. Now, of course, if the fever gets too high, yes, it needs to be treated. But if it's a very low-grade fever, pyrogens that increase fever actually sequester or hold back iron and the spleen and the liver, not allowing viral cells to use that, and they need that to replicate. So it does actually hinder pathogens from being able to increase in number in your body. Okay, so a little review. Which of the following is not part of an internal defense system? So we know macrophages can engulf, ingest, eat interferons or chemicals that are released by cells that are infected. So that's part of the defense. They let other cells know they're infected. Lysozyme, it's what's made by cells to help break down other pathogens. And then epithelial cells help keep the outside stuff outside and the internal stuff inside. They're also an important part of forming the endothelial cells, the inner layers of those blood vessel walls. So, of course, red blood cells have nothing whatsoever to do with defense. Which of the following is not true of a natural killer cell when you're comparing it to a phagocyte? So macrophages are the major type of phagocyte. They're the largest, most abundantly found in tissues. That is true. Natural killers are more specific than B and T. They're less specific. Remember, B and T are part of our adaptive response. Natural killers are part of the innate. So that, of course, is not true. Macrophages help get rid of cellular debris. That's true. Natural killers secrete a substance that creates holes, perforins in the membrane, and can cause, that's how they cause the cytotoxic event. That's true. And then macrophages can stay in a tissue, which local ones do, or they travel throughout the body in the form of a monocyte. That's, of course, true. The process by which phagocytes exit capillaries and enter injured tissues is called diapedesis. That's the squeezing out. Margination is the stickiness. Diapedesis is leaving the blood vessel and entering the tissue. Chemotaxis is that alarm that goes off when inflammatory mediators are released. Leukocytosis is too many white blood cells, and diffusion has nothing to do with this. A patient has contracted hepatitis C virus. Which of the following drug therapies might be effective? Aspirin's going to help with anti-inflammatory. That's not going to do anything. Penicillin antibiotic at this point would not be able to really help that much here. Again, ibuprofen just going to help with inflammation. So interferon's going to be the most effective because interferon helps nearby cells stop that virus from being spread. Of course, penicillin helps with bacterial infections, not viral.